Sorry about that. So welcome everybody. It's nice to see you. We're looking forward to a great presentation from our friends Will and Mary and Jared. And we had quite a few people sign up for this, so we're happy for that. So this is our excuse me agenda for today. We'll do our usual welcome, and then we'll do our blessing and introductions, and then we'll turn it over to Will, and then we've inserted a Q&A into our webinar for each section. We have different speakers today, Will and Jared and Mary, and I'll let them introduce themselves when we get to that point. And then we'll do our usual GIPRA, and then a blessing at the end. Next slide. Let's take a moment and do our land acknowledgement. Many of you have already seen this and read it, developed by our Miswaki friends, Ella Keeley and Sean Bear. Okay, there's a part of me, if you could just back up a minute. There's a part of me that wants to read a section of it based on some feedback that I received from a Native friend who says that not doing a verbal report out of this could be seen as it not being important. And I want to acknowledge that feedback, and I want to say that we don't read it out, but that in no way, for me anyway, says that it's not important. But I'll read the last paragraph out of respect for that feedback. While injustices are being committed against Indigenous people on Turtle Island, today we say thank you to those that stand with Indigenous peoples and acknowledge that land reparations must be made to allow healing for our Indigenous peoples and to Mother Earth herself. So that is out of respect for that feedback, that is what I think I need to do when we show the land acknowledgement, to pay attention to it in a meaningful way for those people who need that from us. Okay. So we're going to ask for someone to offer a blessing for us to start our webinar today, and I'll wait to see if there's a volunteer. Okay, well, I'd like to introduce our speakers and acknowledge our special guests. We've got Captain Karen Herod, Jared Stokes, and you see their info, and Will is a popular GPO within our TOR project. So many of you have already met him. So I will, and then we'll introduce Mary at that point when we turn it over to her. So I'm going to turn it over to Captain Herod and to kick us off.
Thank you so much, Kathy, and we're so glad to be with you here today. So I am Carrie Hurd. I'm the Director of the Office of Tribal Affairs and Policy, and our office manages the Tribal Opioid Response Grants. And so happy to be here with my colleagues, Will and Jared. So give them an opportunity to introduce themselves as well and share our presentation with you today, a brief overview of the Opioids Crisis and its impact on American Indian Alaska Native communities. So Will, Jared.
Hello, everyone. I'm Jared T. Stokes, Public Health Advisor for the Office of Tribal Affairs and Policy.
And hello, everyone. I'm Will Longinetti, also a Public Health Advisor in OTAP and a Government Project Officer on the TOR grant. I see a lot of familiar names and faces out there, so thank you for joining us. Can you see the slides? Okay, great. Trying to make sense of this screen here. Okay, so today we actually have two presentations for you. Captain Hurd and Jared and myself are going to give you, as we mentioned, a brief overview of the opioids crisis and some of the data, some of the more up-to-date data on that. And then we're going to hand it over to one of our TOR grantees who's going to talk about data collection at a more local level. But just to get into our presentation, let's see here. So we now have almost 20 years of data to draw from when we look at the opioids crisis in the US. And looking at this data, we see that the crisis breaks down into several distinct waves based on the type of opioid that was fueling the majority of overdoses and overdose deaths at any given time. And so, with the benefit of hindsight, we now know that a lot of this began in the late 90s with pretty dramatic increase in overdose deaths related to prescription opioids. And so we consider that wave one. And as we said, during the late 90s, pharmaceutical companies marketed opioid analgesics to the medical community as non-addictive. You even had Purdue Pharma salespeople telling physicians at the time that fewer than 1 in 100 patients would potentially develop any kind of dependency. And as you would expect, this marketing resulted in widespread overprescribing of opioids, and that in turn resulted in widespread misuse of prescribed opioid medications, and subsequently you saw huge increases in overdoses due to prescription opioids. Following the first wave, with the second wave starting around 2010, we saw pretty significant increases in overdoses and overdose deaths due to heroin. So you see that with the blue wave there. And so that was wave two. And you had prescription drug monitoring program, prescription limits and more aggressive prosecution of pill mills, which reduced supply of prescription opioids. So governments implemented these kinds of measures in response to the overprescribing and illicit use. And then in the years after these measures took effect, starting around 2010, you then saw rapid increase in the heroin overdoses, possibly as a result of reduced access to prescription opioids due to some of the more aggressive clampdown.
So as Will and Jared were putting this presentation together and we were discussing this, I remembered during this period, I was the director of an outpatient ambulatory clinic, a tribal clinic. And, we recognized as we started getting partnerships with the state PDMPs, we really drastically reduced our prescribing of these medications. And I was thoughtful of Maya Angelou's words of, as we learn better, we do better. And, we inadvertently, with that kind of really aggressive crackdown on prescribing, we didn't understand that we were driving patients to the illicit market because we didn't have adequate treatments, for opioid use disorder. And so, as we move forward, thoughtful is as we, reduce our prescribing, we want to make sure that we ramp up treatment options, for our patients. So just kind of like a remembrance of that history, and maybe some of you may also have those memories as well.
Thank you, Captain Hurd. And then we move into wave three. Starting around 2013, as we began to see significant increases in overdoses and overdose deaths due to synthetic opioids. So you can see the purple line and the pretty dramatic increase there in the past 7 or 8 years. Around 2013, as I mentioned, we began to see significant increases in overdose deaths involving synthetic opioids, especially illicitly manufactured fentanyl. And we attribute it to illicitly manufactured fentanyl because we haven't really seen a significant increase in fentanyl prescribing. And now we're in a situation where, as many of you know, fentanyl, just about every substance is found to be adulterated with fentanyl, heroin, counterfeit pills, and even methamphetamine and cocaine all seem to be cut with fentanyl. And in 2019, synthetic opioids such as fentanyl were involved in over 70% of all the opioid overdose deaths. So it is now these, synthetic opioids that are fueling the opioids crisis. And so the opioids crisis is now a full-fledged public health crisis with devastating consequences. First and foremost are the deaths, and close to 1 million people have died from a drug overdose since 1999, most of which were opioid overdoses. And in 2020, which is the last year that we have final data for, we know that at least 91,799 overdose deaths occurred in the US, and opioids were involved in 68,630 of those deaths, or 74.7%. Drug overdose deaths often require lengthy investigations, toxicology testing before a death can be definitively, attributed to a specific substance. So, that can take months before we have final, death counts, cause of deaths. So that creates a lag in the data. But what we do have is provisional data, which relies on provisional counts. But it may not include all the deaths that occur during a given time period. But provisional data is better than nothing. And the provisional data from the National Center for Health Statistics and the CDC indicates that there were an estimated 101,035 drug overdose deaths in the US between October 2020 and October 21, which represents a 28.5% increase from that same period the year before. So even though we don't have final data, the provisional data we do have seems to indicate that there was a pretty significant increase in the past year. And due to COVID, there's been some interruptions in the data collection. And again, we know that synthetic opioids are the main driver of the crisis right now. Apart from the deaths, there have been other pretty harmful consequences from the opioids crisis, including the increased incidence of neonatal abstinence syndrome from opioids being used during pregnancy, and also the spread of hepatitis C and HIV from injection drug use. And then here we have a map of the increasing death rate over time from 2003 to 2020 by county. So you'll see as the counties get more red, that represents the death rate increasing, the number of overdose deaths out of 100,000 over time. So it's going to go from year to year up to 2020. So you see pretty dramatic increases across the United States. And then within the past 7 years or so, I'm sure many of you have seen increases in the availability and use of psychostimulants such as methamphetamine and cocaine. And some people are saying this is, effectively the fourth wave of the opioids crisis, because folks are seeing so much polysubstance use, and a lot of these overdose cases don't involve one substance, they involve multiple substances, including opioids and meth, or opioids and cocaine. So you could make a case that stimulants and polysubstance use represent the fourth wave in the opioids crisis. And this has major implications for how to respond to the crisis, given that there's no pharmacologic treatment currently approved by the FDA for stimulants. And the stimulant use patients tend to have a different profile than maybe your opioid use patients. And at this point, I am going to turn it over to my colleague, Jared Stokes, who's going to take it from here. Jared?
All right. So the opioid crisis has had a different effect on various racial or ethnic groups. However, when we look at American Indian and Alaska Natives specifically, we find that they have been greatly impacted by the opioid crisis, specifically when it comes to incidents of opioid use disorders and mortality rates from opioid overdoses. So we can compare this to national trends, and we see that tribal groups tend to have significantly higher rates of opioid overdoses than the general US population. We look at specific data. So if we can go to age-adjusted annual mortality rates for opioid overdose mortality among tribal groups, we see that from 1999 to 2016, the death rates per 100,000 rose from 2.9 to 13.9 deaths from 1999 to 2016. Now, according to the IHS, we see that death rates for tribal groups from prescription opioid overdose increased from 1.3 per 100,000 individuals to 5.1 per 100,000 from 1999 to 2013. Next slide, please. The Pew Research Center specifically compared drug overdose death rates for different racial or ethnic groups from 2015 to 2020. Now, this is specifically drug overdose, but we have reason to believe that opioid overdose is definitely heavily involved in this graph that we see right here. So for tribal groups, tribal citizens, we see that for men specifically, tribal men or Native men, they only lag behind Black men regarding US drug overdose death rates per 100,000 people from 2015 to 2020. However, when we look at Native women, we see that they lead all over other women regarding US drug overdose death rates per 100,000 people from 2015 to 2020. Once again, this is data that the Pew Research Center looked into. Next slide, please. When we look at opioid use among Native youth specifically, we also find some alarming trends. Specifically, we looked at this study by Stanley Crabtree and Swain in 2021, and they studied American Indian adolescents specifically who are attending schools near or on Native reservations in the US. And they compared this to the general US population youth in grades 8th, 10th, and 12th. And they compared the youth in grades 8th, 10th, and 12th for the general US population to American Indian youth on reservations regarding opioid use. And what they found was that American Indian youth demonstrated significantly higher past 12-month or 30-day opioid use relative to the national sample, except for when it came to Vicodin or 8th grade use of heroin. So what that means is when it comes to Vicodin specifically or 8th graders using heroin, the national sample of youth was higher than American Indian youth. Next slide, please. We also have evidence to believe that the COVID-19 pandemic in 2020 led to higher rates of opioid use among use among tribal citizens. So we looked at this study specifically by Friedman and Hansen, and they did a cross-sectional study that calculated drug overdose death rates per 100,000 population by race and ethnicity from 1999 to 2020. And what they found was, next slide, please, that Black individuals had a larger percentage increase of overdose mortality rates in 2020. And this actually coincides with the Pew Research Center data that we looked into earlier from 2015 to 2020, that Black individuals, when you take Black men and Black women together, they had higher rates of opioid overdose mortality in just a period of time, like if you combine them together. However, for tribal citizens or American Indian, Alaska Native individuals, what we find is that what this study found was that they had the highest rate of overdose mortality, drug overdose mortality in 2020 compared to other racial or ethnic groups that were shown there. Next slide, please. So when looking at a third study, we see that ways to address the opioid crisis among tribal groups have been looked into. This study specifically looked at two databases that were operated by SAMHSA. They looked at the 2018 National Survey on Substance Abuse Treatment Services and a 2017 treatment episode data set admissions. So both data sets estimated the extent to which medications for opioid use disorder is available and used among tribal groups across the US. Next slide, please. And what the results found is that medications for opioid use disorder among tribal groups are offered at similar rates as other facilities, but were less likely to offer methadone or buprenorphine maintenance that are most effective in reducing overdose risk. And they found that the lowest use of agonist maintenance was in facilities run by tribal governments, the IHS, and with staff that speak native languages. The authors of this study found that there are certain barriers to the uptake of medications for opioid use disorder, specifically when it comes to using evidence-based treatment practices that is largely accepted by the general US population. So when compared to tribal citizens or what they deem appropriate, this study found Western influences are not necessarily accepted a lot of times compared to more tribal practices. And for that, to explain more on that, I'll let Captain Hurd take over this part right here.
So we just wanted to share on this slide that we're cognizant that many of the tribal opioid response grantees combine both Western and traditional practices in their treatment value. So it really doesn't have to be an either or situation. We heard a few weeks ago from the Choctaw Nation of Oklahoma specifically how they were combining these practices. And I believe with the TOR grant, that's kind of a unique aspect to have that degree of flexibility. And I'm excited that the TOR grant is informing SAMHSA as a whole about the importance of inclusion of those cultural practices, along with maybe more Western-based medications for opioid use disorder and other evidence-based practices.
All right, thank you, Captain Hurd. So also another point that this study made was that the lower uptake of medications for opioid use disorder among tribal groups may also reflect insufficient access to resources to expand treatment services for opioid use disorder among tribal groups, which is a particular challenge across tribal and IHS run programs that have been historically underfunded. Next slide, please. So what is contributing to opioid use among tribal groups? We have some factors right here. However, these factors are also similarly found with other marginalized racial ethnic groups, such as higher unemployment, lower income and higher poverty rates, poor physical health, limited access to adequate education. However, tribal groups, they specifically and they uniquely have the added factor of historical trauma, which is in the next slide. And historical trauma is pretty much, it speaks to this loss of culture, this loss of identity through US history. For those who know more of US history, that historical trauma that Native individuals have had to deal with has had a lasting impact on their generations today. And this graph right here, or this picture right here that was taken from the Treatment Improvement Protocol 61, which is from SAMHSA, it kind of shows this cycle of historical trauma, how historical trauma can impact an individual, can lead to traumatic stress reactions, which in turn leads to methods of coping from this, methods of coping with this traumatic stress and grief, and that can lead to substance use and abuse. And because of that, that can also lead to increased risks of other traumas. So someone feels a loss of their history, they cope with opioids or they cope with other substances, and then they might be more prone to violence, or they might be more prone to other negative health impacts. Next slide, please. So when addressing opioid use among tribal groups, we run into certain barriers. And this right here, these right here were some barriers that were identified by the National Congress of American Indians. And these, and what they say is that Native Americans, tribal groups, American Indians, Alaska Natives, they refer to them as the asterisk nation, because a lot of times when we're looking at data in order to address the barriers to helping with opioid use disorder or opioids among tribal citizens, we don't have enough information. Now, there are 574 federally recognized tribes. However, some of the smaller tribes might not be represented in certain studies. And because of that, we might not be able to adequately address different groups within tribal nations. Next slide, please. So as I said before, you have smaller tribal nations. And then another area that was pointed out by the National Congress of American Indians was undercounting of American Indian and Alaska Native youth. So this undercounting can have serious impacts when it comes to the distribution of federal and state funding. And for this, I'll let Captain Hurd also interject once again.
So as we were having these discussions, we were discussing the 2020 census, right? And the huge increase in Native population for the U.S. I think there was, it was over like an 86% increase. And a big part of that increase were American and Alaska Natives that considered themselves more than one race. So it was a total of 9.7 million, which brought us up to 2.9% of the population. But 5.2 million considered themselves more than one race. And this was a change that was made in 2010. But I wanted to bring this to light, though, because we still see a really significant undercounting of reservations. In some estimations, it is like over 5%, but then other people have it kind of even higher. And a big reason why this is so important is so many of the federal dollars are tied to these census numbers and representation. Additionally, though, we know that, we have federally recognized tribes, which the U.S. government has a political relationship with, right? But then we also have, how do you define a tribal member, right? We have state recognized tribes. And so I think just kind of like who is like an American Indian or Alaska Native and how do we define that kind of like really complicates a lot of this data.
Thank you, Captain Hurd. And even going with definitions, we also look at the definition of Native American or Indian in general. Sometimes when we're looking at studies or research, we're seeing that there is no consensus on what kind of definition are we using in order to define this population. And even referring back to the previous slide, we look at reasons for this kind of confusion. There are inaccurate media images of tribal citizens. We have lack of historical and contemporary awareness in areas such as schools, healthcare facilities, and everyday life. So just kind of being more uniform in terms of how are we defining this population, how are we defining these individuals would definitely be helpful as well. Thank you, Will. And then we'll go to the next slide after this. Yes, so we talked about the barriers. Now let's talk about solutions. How do we address the opioid crisis among tribal citizens? How do we address substance use disorders among American Indians and Alaska Natives specifically? One thing that has been a common theme in a lot of the research that we've all looked at has been just addressing the cultural loss among Native American communities. Now, I think back to a paper that I read a while ago, just talking about how a lot of times youth having a more of a connection to their culture can help with their future outcomes. So yes, exactly. Thinking about like powwows, thinking about just knowing one's history, that can definitely be helpful to helping with the opioid crisis among tribal citizens. Specifically, I'll look at this third bullet point through reconnection to American Indian and Alaska Native communities and traditional healing practices. An individual may reclaim the strengths inherent in traditional teachings, practices, and beliefs and begin to walk in balance and harmony. I thought that was a great point that was made there. Next slide, please. Specifically regarding just SAMHSA, the Office of Tribal Affairs and Policy, we look at the tribal behavioral health agenda as a solution to also helping with opioid use disorders and the opioid crisis among tribal citizens. So the tribal behavioral health agenda is a report that comprises a collaborative tribal federal blueprint for bettering the behavioral health of Native Americans. The tribal behavioral health agenda was developed in response to tribal leaders wanting to improve collaborations with federal agencies to address the behavioral health of American Indian and Alaska Native communities. And once again, I'll turn this over to Captain Hurd.
So I just wanted to acknowledge briefly, really kind of the labor of love. I think that the National Tribal Behavioral Health Agenda was for those that volunteered and worked on it. As we find ourselves, I believe now 6 years after the publication. And so our Assistant Secretary, Dr. Delphin Rittman, and our SAMHSA Tribal Technical Advisory Committee has asked OTAP to take the lead in taking a look at the National Tribal Behavioral Health Agenda. It was really meant to be a foundational document and a roadmap about how the federal government should coordinate, within itself, and then also with tribal nations. So what we're doing is we've been instructed to take a deep dive into the document to look at the data, to see where we have successes and see where we still have opportunities to do better moving forward, and kind of bring this document back up into the forefront of the work that we're doing. So we're taking that on. We're going to be reaching out to you soon with the creation of a tribal federal work group to work toward really looking at this document and seeing how we can use this, as a path forward as well.
Thank you, Captain Hurd. Will, next slide, please. So we also have commitments from the Biden-Harris administration, and I won't go too into depth about this, but after the events of COVID-19, the pandemic, there have been a strong push to help tribal citizens, tribal populations overcome their new challenges that could be contributing to opioid use amongst these individuals, these populations. So specifically, I'll highlight the American Rescue Plan Act. So this was signed into law by President Biden on March 11th, 2021, and it invests $1.75 billion in American Indian and Alaska Native government programs administered under the oversight of the Department of the Interior's Assistant Secretary of Indian Affairs. Next slide, please. So we also have to mention TOR, Tribal Opioid Response Grants, to which Will is obviously working in. And this program aims to address the opioid crisis in tribal communities by increasing access to culturally appropriate and evidence-based treatment, including medication-assisted treatment, using one of the 3 FDA-approved medications for the treatment of opioid use disorder. And the intent is to reduce unmet treatment need and opioid overdose-related deaths through the provision of prevention, treatment, and/or recovery activities for opioid use disorder. Next slide, please. And so here are some data sets that you can access just to see the opioid crisis, how it's impacting tribal individuals or impacting other racial and ethnic groups in general. And we definitely will send out the slides after this presentation so that you all can visit these links and you can see these data sets for yourself. And with that, that is the end of our presentation. Does anyone have any questions?
Yeah, thanks, Jared. If anybody has any questions, please feel free to put them in the chat or unmute and let us know what questions you have.
I was wondering about Native researchers, if some of this research was conducted by Native people within Native communities. And I really like those articles, Stanley, I can't remember, Swaim, Friedman and Hansen articles. They were articles, right? Yeah. Yeah, is there any way we could get a link to those articles?
So we actually do have I can provide the link in the end. We have a references section at the end, all of everything that was mentioned here. Yeah,
okay.
It took a while to put that together, but yeah, we have all the references.
Oh yeah, it looks like it might have taken a while, right? Yeah, because I looked at some of those data sets, and there was an asterisk in the last 2 years, actually, on the data for opioid specific issues. And I was intrigued by that. And I'm glad to hear that people have experience with that people are acknowledging the underrepresentation, and that there's some movement happening in the Indian country to rectify that.
Yeah, we found that even in, SAMHSA's own data sets, like in the NESDA data for 2020, a lot of that data is suppressed because we didn't have a big enough sample set. So I'm hoping that 2021, and a lot of that had to do with COVID and being able to conduct that research. So just giving an acknowledgement for that I think that, it's a struggle that people are trying to identify and address.
Yeah. I was just thinking, as I was looking at the data in the part that Will went over, I started to feel really sad. It's like, wow, that is a huge difference. It was like, it wasn't so much eye-opening because I've been involved with TOR and I hear the stories and that people are working through in their individual communities, but it's still remarkable, the amount of suffering that people are going through. And on the other side, there is a lot of hope too, because there's some really, through listening to people in the TOR, how they're using their money to address this, there's a lot of creativity and a lot of good things that are happening as well.
See, someone has their hand raised.
Hi, everybody. My name is Jamie Ann. Tlingit Kena Zechtin Ayachsai. My Tlingit name is Zechtin. I am Alaska Native. Deshitan Ayahut. Glake Kayati Ayahut. I come from the Deshitan clan in Gunquan, Angoon, Alaska. And I'm one of 4 Alaska Natives who have been chosen to participate in the RX awareness campaign with the CDC that you can see in my background here. And this is really big, I think, for Indian country to know about. There's 4 of us who share our stories. There are 600 agencies who use our stories as training for to reach our Indigenous people across the nation, so that they have hope and familiar faces with attached to that hope. And so I did put in the chat the link to this. I think it's really useful information. We have some videos. You can see the person next to me. Her name is Jenny. She's my friend, and we've been on this healing journey together for several years. And her story is on there. And then also Stevie Ray. So I really connect with these 2 people. Our stories are very similar in nature and can be repeated across Indian country, stemming from the residential boarding school institution eras and all of the abuses and things that go along with that historical trauma, as well as our own life trauma. So I just wanted to introduce that. I'm so sorry that the time that I had on my computer said 10 to 11:30 Alaska time. It sounds like I'm at the tail end of this training, and it's only 10:44 here in Alaska. So I think the time might be wrong, or maybe I'm not too late.
We have another presentation, so you're not too
Oh,
late.
Great.
Yeah.
Fantastic.
Our apologies for that, but thank you so much for sharing.
Yes, I encourage all of you to go and take a look at this, because there's posters, there's training material, there's all these facts, and again, that familiarity of having this look is hopeful to others, to let them know that they're not alone on this healing journey. So Gunesh Chish, thank you in my language.
All right. Well, I know we'll have some time at the end if any other questions come to mind, but at this point, I would like to turn it over to Mary Lask, She is a TOR grant recipient. She's the fund development coordinator at Reno Sparks Indian Colony, and I've had the pleasure of working with Mary since 2019 on her TOR grant, and just been so impressed with what she's managed to do, building a pretty sophisticated data collection program kind of from the ground up. So Mary, I will turn it over to you.
Thank you, Will, and thank you for that introduction. Yeah, I've been with Reno Sparks Tribal Health Center since 2015. It's been a real experience and journey, and I've learned a lot on basically the clinic operations and so much more. So I'm going to go ahead and start my slide here and let me know that, can you guys see it? Did it just come up? Okay. So a little bit about my background. In 2002, I was a research assistant for the university. Back then, I was asked to be a grant person and to collect data. And I told them absolutely not. I needed to know more about the people I served. And to get really involved, I chose a counseling career at that time. And from there, I was better equipped to get involved with people and kind of understand their stories, and then learn to lead them along a way to a different path of sorts. So currently, like I'm a fund development coordinator. I've taken that on, so I write grants, just like I said I wasn't going to do, and now I'm doing it. So in the entire time, I've always been led to do data. So it's basically basics of data collection and programming to improve standardized services for at-risk identification and improving how we deliver modalities of treatment. But how did I get to this? It's what's your story, basically, right? So what's my story? My story, and I'm just going to read it because it's going to be easier for me to say. My personal story growing up is I lacked vision. I found that learning was next to impossible. I felt completely lost. I was out of place, and I knew I was missing something. And I was missing it for years, where I was struggling in school till about 5th grade. Stumbled through it and found I wasn't too smart. Information did not come to me. This made me really socially awkward. I mean, just were involved with peers or anything was next to impossible because I was so out of place. Then something happened. Something changed. I was in a car and I was asked to read a sign. And I said, it didn't say anything. There was nothing on the sign. And this was a stop sign. So after that, I found out that I couldn't see. So I was missing a lot more, than literally I had no vision. That's a big deal. And I saw things for the first time, and that changed everything. And that changed how I see things, like trees had leaves, grass had blades. I could see and make out a world that now it's my personal playground. And I have taken that to such a level that everything I do, it's my personal playground, gathering information. And my journey is to become kind of like a storyteller and gathering information and then presenting the information so that way we can kind of make a better story and come up with a better ending. So the story goes. So my story, like others, has blind spots, right? And so what I'd like the audience to do is to take your hand and put your hand in front of your face. And when you do this, this is kind of like the blind spots we're talking about. You can't see everything. When this happens, your perception changes. You have fears, you become uncomfortable. And you can take your hands down, but that feeling you get when you can't see everything, it can make you anxious. It can make you feel particular things. So the idea is, okay, we have blind spots. Now, what do we do about it? I gotta move this so I can see, is building resilience to finding areas of strength. It's looking at where are the blind spots? How can we gain information? How do we know what the risks are? And especially like related to the tribal opioid response grant is what are the risks associated with medications and such. So once a risk factor is found, then it's resolved with adding multiple protective factors. The idea is to wrap something around it to make the treatment optional. And so many times we look at, okay, it's just an opioid. No, it's much more than that. And the entire person that we're treating needs to be looked at in a different way in order to make the whole system better. So this is done basically by fact finding to make a story basically come to life. It becomes living and breathing. And to ultimately write a better health story to a successful new chapter. And this can be done in any clinic setting, any tribal community. It's just taking the pieces and figuring out what you want to know. So based on that, blind, but now I see. So there you go. You know, that's my story. So now getting to the bits and pieces is here is basics of collecting data is one, how do we tell our story? One, you assess the need. Two, you define the need. Three, you describe what needs to happen. Then the basics is include relevant, significant information, record it in a timely manner, make a code book of the information you're tracking. That way you have documentation that everybody can follow. Use your team of unique stakeholders and specialists to note changes and adapt strategies for positive outcomes, create forms and policies to adopt the treatment modalities that you want after you get the facts. This is kind of it in a nutshell, but now I'm going to go into what actually happened for the clinic that I worked for and how did I get there. So this is completing basically the workflow map for each area defined for the particular clinic I work for, Reno Sparks Tribal Health Center. That's defining the needs and creating the story for them with the use of the funding. Is one, you have to define who are you going to talk to make everything happen. And with tribal communities, some people know about them, some people don't, but you have to identify the game players. Who are your stakeholders? Who's going to be involved to where if they become aware of the facts that they can change the story with you. And these are the members, basically. You've got your tribal chairman, the tribal administrator, tribal council needs to be involved, the tribal health board, the tribal legal team, tribal community members, tribal family members, tribal patients, and tribal employees, top to bottom. If you get them to support the story, it will become reality. The thing is, it takes time. Anything done in a regular clinic is done maybe a little faster, or maybe not, because when you have all these players involved, it becomes real, tangible, and doable. So, and it's once they're involved, it becomes policy and procedures over time. So one, provide the facts to the stakeholders so they can make a decision with each storyline, basically the data. Provide training from the top of the leaders, then community members, followed by employees, then patients. It's the idea is you got to get the leaders involved with what you're wanting to do. And then when they're on board and they have those questions answered, then everybody else is involved. Anything that I present to tribal council or to the health board, I make basically a table of contents. I do all the information that I gathered, and then I do an abstract of what all that information is in a very sweet summary. So, and it typically, doesn't leave any gaps, and it fills in information to where they can make a good decision based on the facts that they're given, versus, just talking to them. It's give them the information. I mean, that way, and let them have the time to really look at it. So this is the information related to the grant. This is the storyline, basically. Creating the plot for the story. This is the code book that started the TOR grant here. This is me, the project director. Then I did the medical stability quick screen. This is a high risk assessment that was developed specifically for Reno Sparks Tribal Health Center. It looks at all kinds of things. It looks at the disability index. It looks at factors of insomnia, anxiety, depression, the opioid risk tool. And it looks at strengths and weaknesses and treatment plan options. And then it does a timeline of each time you test of what changes the patient goes through. The other thing we needed to look at was diagnosis codes. Is when we're treating a patient that's on medication, we should be looking at how often are they seen, what are their diagnosis codes, and are those diagnosis codes changing based on adding treatment options? So initially it was, okay, I'm only tracking opioids. Then first thing I saw when I was looking at the opioids and I got the high risk medication list is, wait a minute, some of these patients are on not only opioids, but they're on sedatives, they're on benzos, and they're on Lyrica, and they're combining these. So bringing this to the clinic's attention was a big deal. And once that happened, we changed things how we did. We started a benzo clinic, and we started a post-acute withdrawal group. So that way we could titrate the patients off the medications and get them on one medication and then reduce the doses. So part of it also was setting alerts in the system related to when risk assessments were due. We developed a contract for acute and chronic pain. Acute is for like a 14-day supply, and then chronic is for anything over that. And those contracts are done annually. And if they have a change in provider, then of course a new contract would be developed. So, and here we did not only, initially I looked at like the opioids and did not put a morphine milligram equivalency. It's very important to track medication related to how much they're getting. So we added that to the model, and we're able to actually, initially the policy was like 90 MMEs, which is morphine milligram equivalent. So we changed it to 60 based on, we're not a pain clinic. We need to keep them medically managed, and we still were able to titrate them down to a lot lower. So let me go to that information and develop. This is the basically the review team that identifies the action plan for every patient that we see. And it kind of just does the model of, it used to be monthly that we staff them, and now it's a hot wash that every single day we use this model in the morning. So we are able to assess the risk, we're able to get them into the right programming, and provide just more systemic, better care. So, oh, sorry, there we go. And back it up. This is the next one. There we go. Adding to the story to make it sustainable is some of the things we had to do is like working with the stakeholders, is developing and implementing an intake packet. This intake packet to get approved took a good 3 or 4 years. It went to the health board. It had some fixes, went back to the health board, then it went through tribal council, went all the way up, and then we had a change in staffing with behavioral health, so it was held up. Then finally, just as I was closing out the grant, the intake packet was approved, and it was just, it's a great tool. And it basically does the blueprint for everything that needs to happen. Prior to that intake packet, we had 3 forms. We had a grievance procedure, we had a consent form, and the other one was related to release of information. That was it. And that's not enough to effectively run a program. The other thing that was required to make the story stick is a new policy and procedure manual that melded mental health and substance use with multidimensional modalities of care. So this was added, and it's still in the approval process, but it has been written. And SEPTA did certify us with it. This is the process map that was made to treat patients with long-term opioid or stimulant analgesic patients. So if you look at the model, it'll go through and basically tell you everything that we offer. And it has worked really well. Because we don't have MAP programming at the clinic, we're able to contract with the Center of Behavioral Health and New Frontier Treatment Center. So this is the lower level of MAP programming. This is the higher level for inpatient. And this one here is like related to opiate stimulant use disorder, kind of a simpler model that it goes through of what tests we do. Again, the centers, the referral process, and every story has to have a good map. If you have a good map, anybody can follow it, and the basically story becomes reality and having more effective patient care. And how that is shown with the clinic that I work with is here. This is the trends. The green is what we used to prescribe in opioids. This number has drastically been reduced. We were prescribing on a monthly basis in 2018, 280 opioids per month. Currently, that number is 31. And that is an astronomical shift that shows those maps, the policies, the intake packet, the whole process, it worked. The next is Tramadol. One of the other ones we are tracking is we were 98 every month, 2018. Currently, that number is 9. So that is a huge reduction across the board with each doctor that is paneled here. The Lyrica was another one that's still 72 per month, and now that number is down to 11. The benzodiazepines, that was 111 patients. That's quite a bit of benzos. And number now is 13, and out of that number, when they prescribe, it's not they're getting 30 or they're getting 80, they are getting about 5 pills. So it's completely revamped on being a very short-term medication used at the clinic. The Ambien is another one that we had 14, which isn't too high per month, but how we prescribe it is they can only have 5 pills per month. So now we only have 3 patients on the Ambien. This is kind of like the nutshell of the chronic pain and the acute pain. So out of that 31 opioids, there are 25 that are on it for chronic pain. The other patients are on it for acute pain, which are 6. Tramadol, we have no acute, and under Tramadol for chronic, there are 9. So, I mean, basically 40 patients are on opioid or Tramadol medication, which is a huge accomplishment for the clinic. Our medical stability quick screens is the tool that kind of helps gauge and us look at the top 3 diagnosis codes, how to tie in other treatment modalities, like we've looked at the alpha stem, acupuncture, chiropractic, the wellness center, getting them, and I would walk them downstairs and show them all our different programs and get the patients involved. We did Naloxone Kits and getting families involved. What does an overdose look like? It's all good stuff. So on this medical stability quick screen, this tracks like we do now, we have 14. Total current count is 34. That's a record number low. We used to have up to 300 medical stability quick screens when I started this, and trying to track those was next to impossible. And I was like, okay, we've got to change what we're doing, because what we're doing now isn't doing the patient any good. I mean, we've got to have a better way to treat them. So the end of the story, we did. We have team approaches to caring for patients systematically, improved tracking of referrals, improved modalities of treatment, reduction of long-term use of high-risk medications, improved well-being and wraparound services, healthier patients with reduced symptoms and better management of health needs, biologically, psychologically, and socially. End of the story is a story with renewed energy and how we provide care and apply harm reduction approaches for sustainable change for effective, realistic care that better serves our elders and community members. And with that, basically, data writes the story, listen, and what comes next is vision. This is constant and growing. Any questions?
Thank you, Mary. And if anyone has any questions, you can either put them in the chat or just unmute and feel free to ask.
Is that medical quick screen open domain? In other words, can other people use it or see it?
They can. It's www.msqs.org. However, you do have to pay to use it. And we have like a license for as many as providers as we want, that we can all get onto it. And yeah, it's a great tool though. Good question.
It sounds like it measures medical and behavioral health together.
It sure does. It measures behavioral health, it measures medical, it measures mental health, it measures ADLs related to everyday life, and then it tracks them and trends them. And like, say if a patient is high risk, if they score poorly on it, it's going to document that. And when it does, our doctors are alerted that, okay, this patient has to be seen a minimum of every 90 days. Versus if it's moderate, it's every 6 months. If it's low, it's once a year. So, and then we're able to also tell, is what we're doing effective? Has there been a significant change? And with this, it shows it so quickly that we know on the fly that there has been a big change. And then it has all these wonderful graphs and explanations in it, and tells you, or makes recommendations based on the information it has. So the data. So it's been an invaluable tool, because initially you were like, okay, we're going to do the opioid risk tool. And I was like, that's not enough. We need a bigger picture. So that's when we started working with actually the professor that developed it. We had influence on what we wanted in it. And so it was a thing that we did together. And this is when I was the program supervisor for behavioral health, that this came to be. And it was before actually I took the position as the opioid point person. So.
We have some questions in the chat, Kathy. So someone else put in the link to the MSQS tool. There's also a product information link that I will put in the chat in a moment for that tool. Tamara would like to know if you would be willing to share your behavioral health medical policy.
I could do that. Yeah.
If you want to email it to me, I can include it in the slides when we send that out.
Okay. Yeah, that, because yeah, it's all the way down to our intake packet is also really good. I did kind of briefly go over the different parts of it, that it has patient rights, it has urine drug screen in it, it has wraparound services that we didn't have before, is acknowledgement. It also has, like in it, so many times when we go to treatment, we don't tell them what the risks are. That when you get seen, things might get worse before they get better. And patients need to know that. So we, we kind of have a person that is our BH case manager, and they go through all of this. So that way they're going to be more apt to come again, because they know, okay, I'm going to have some anxiety. I could have some insomnia related to this, or my headaches will increase because I'm dosing down on medication, and if they're informed, they're going to have buy-in, and then they're going to understand why they're feeling what they're feeling. So, and all that was kind of written in all this, the policies as well as the intake packets. So.
What kind of timeline did it take to develop the training materials and then do the training of all the stakeholders?
A lot of timing. For instance, the intake packet, it took, I wrote it with the specialty team, had them review it, and it was a panel of people. So I had the medical director involved at the time. I had the pharmacy manager. I had some medical providers that were interested. I had some behavioral health staff involved. And we went through and basically I wrote the forms as drafts, and then put them up on screen. We'd have these big presentations with basically PowerPoint together, and then everybody put input, and then I would retype it on the fly right there. And then we would make the change. And then finally, I think it was after 4 or 5 times of meeting that it was there. We got it, and then we were able to say, okay, it's going to the health board. Went to the health board, and then some members weren't there, so I had to represent it. So I was like, no, we want to hear about it too before we approve it. So then I was able to present it again. It was very well received. Then there was some stumbling blocks. It went through tribal council, went through legal, made the changes according to the attorney, so that way we had everything nailed down. Went to tribal council, COVID hit, and meetings were canceled. And of course it was on that agenda for, and then we didn't have it. So, and then finally when we did, everyone had forgotten about Mary's intake packets. So it's like, okay, let's redo this again. And because I was no longer in the position, actually Dr. Lauren Nielsen, the BH manager, is the one who presented it and got it to pass council, and now it's actually being used. And it just started getting used probably about 3 months ago. So it was a long process. And one, because we've never had a urine drug screen policy in place. Why did we need this? This is a good opening here, is we needed this because when I did the audit on how often we were drug screening the patients, there was 12 patients we were drug screening in a 6-month period out of those 280 that we were prescribing. That's a huge gap. There's a problem. And that's when we looked at building the acute and chronic pain contracts, which ties in typically every 90 days that patients need to be tested, including patients that aren't on prescriptions, because we don't get a clear picture of what's going on with anybody unless we have these urine drug screens to kind of get a baseline. And it's just really important information. But getting that buy-in was really hard because we hadn't done those before. So it was intrusive in nature. And but if you look at the clearer picture, it's going to make you better And some people are not going to tell you what they're taking unless you see it on a drug test. Then you can give them the services to make them better. And the idea is to always present it as, we're going to make it better. This is the information. Let's do this together. Part of it also started with the Naloxone Kits, was talking about overdose. Initially, I worked with tribal council and the health board on that. And we provided the kits. We did the presentations. They asked as many questions as they needed to related to what does an overdose look like? And, what can we do to change it? Is naloxone harmful? And no, I mean, you can take it all day and it's not going to hurt you. It's just going to stop the drug from working temporarily in your system. So it kind of, changes the receptors temporarily, but it will come back. So go to the emergency room after, you give somebody the naloxone, that kind of thing. But once they were on board, then all of a sudden, everybody else was on board. I was getting community members calling, asking for personalized training. And I was like, well, wait a minute, why not change it and prescribe it to every single patient that has an opioid? We weren't doing that. I was giving them out to families, and I was giving them out to the police, social workers. And then I was like, no, we need to give them out to the patients, and we need to give it out to the family. And now it's just part of the protocol is that every patient that's prescribed gets a naloxone consult and gets their naloxone. The thing we added to that most recently with the new project director, Charla, is we're going to be adding 3 naloxone kits versus 1 because of the fentanyl, that we've had this increased surge. So 1 or 2 kits isn't going to wake them up. It's not going to get them to respond. So that 3rd one will give them that push to get them safely to that hospital for treatment. Other things that we found is the surge of stimulant. Based on that, we're changing how we're doing the prescriptions. And that was, now they come to me and they're going to come to Charla, the new project director. On the fly, they just said, Mary, medical director, the health director, or we want stimulants added to the medication list. So now we're going to be tracking stimulants. And not only are we going to be tracking stimulants, but we're going to be tracking anything that comes into our pharmacy, because we have our own pharmacy. Any provider that prescribes for our patients, we're going to be following that list. And the providers are going to have a list of all the outside providers' prescriptions so we can better treat the patients. So they may be only on a 60 MME morphine milligram dose with us, but maybe they're on 150 with the outside provider. This is need to know information. So this is being added, and it was asked for. So I was like, absolutely, we're going to make this happen, because it's all about systemic care and following up with referral sources for our pain clinics. Because yeah, our numbers are 31, but what is the real number for the patient population that we're serving, outside through pain management and other providers, in a sense. So those are some of the changes. Any other questions?
Well, there's some comments. People are very interested in the intake packet that you're describing, the policies, everything that you just mentioned that you're willing to share. You can send them to Meg.
Okay.
And we will get them out to the registrants to make sure they have that, if that's open for sharing to people. So hard copies is what I'm hearing, because I think that people are impressed with what you're saying, and they go, send it our way. Is it importable? Yeah.
Well, that way, yeah, because it's when you build something, and I was lucky enough to where the story has come to life, and this tribal community has allowed me the privilege to be part of this storytelling and making a new way of treating patients. This is just one of many things that I've been allowed to be involved in. And I'm glad that I can be a good influence, and that the changes are happening. And it's once you get involved and you get the tribal leaders on board, it's easy to change. And the buy-in's there because you're part of the solution, you know. And it's always about, when you look at data, it's all information, it's all vision, it's all seeing. And me as a child not seeing, whole new world for me, and how I, you know, broke things down.
Yeah. So true. Yeah, that was a nice story. Thank you for sharing that story.
Sure. And one other thing I should probably tell you, that ties my stories together, is the other gap I had is with my family. It was always like, okay, I'm so different outside of my vision. And why am I so data driven? Why am I who I am? And January 2022, my mom finally said, I don't look like my sisters. I don't look like sisters. I have a different dad. Oh, no, you don't. Oh, you know, no. I'm doing a DNA test. And I'm thinking I have a different dad. And sure enough, I had a different dad. The DNA showed I was like German and not French. So I'm like, okay, what is this? What is this?
That's a big secret.
It's a huge secret, but the secret comes out. And I learned my father's John Joseph Phillips, MD, general medicine.
Oh, wow.
Yeah, he was a doctor. He built programming from the get-go. He was a board director. I'm a board director, president of the board of examiners for the counseling board. He built outpatient programming in Chicago, and I did outpatient programming, residential and inpatient. Built the first Medicaid program for inpatient care for an adolescent program. Everything that I've done is based on him. And passed away in 2000. And right around when I became a research assistant was 2000. So even though I didn't know anything about him, everything about him came through me. So, you know, it's just that vision, that getting to the bottom of who you are is always intrinsically there. It's tapping into it.
Yeah.
So, and thanks to him, you know, I've never even knew him, but I'm tapping into it. Very thankful.
You knew his spirit anyway.
Yeah, and his spirit knew me. But ancestrally, I think he was speaking to me over and over again, because, you know, his life ending at 72, you know, before, you know, when I never got to meet him. But I am literally just like him.
You're literally his child.
I am, without even, and before I was like, my mom was a waitress, my dad's a gas station attendant. I was like, why am I so different? Sure enough.
And that's interesting.
Yeah.
Well, I really do appreciate the level of thinking that you put into this. And I am especially happy that your tribal community could benefit from your knowledge in such a significant way, really. And your ability to provide help and direction to them as people, as it sounds like it really made it a huge impact on the treatment of people with substance abuse and mental health issues, particularly, as well as medical care. But that's a good example of how data done well with buy-in from the community and the leaders can affect that kind of change in a good way. So thank you for your presentation.
Oh, you're welcome. And yeah, it has literally changed everything. I mean, the death rate, non-existent, and mental health issues so much lower, and overall care is, you know, just a whole lot better. So thank you for that.
Yeah. I got goosebumps when you said the death rate was almost non-existent.
Non-existent, yeah, related to this.
So so many
And
other
before-
communities are suffering from that. And if we have a way to help people address that in the way you have, that would be great. Okay, where are we at? People are starting to move on to the next thing in their day. I am going to ask Meg to do the GIPRA thing.
It is in the chat.
Thank you, Meg. Everybody knows GIPRA. And please fill out our GIPRA, because we take your feedback, and this is just my spiel every webinar. We take your feedback, read it, and make decisions for future webinars based on your feedback and interest in other topics. This topic was based on feedback from last summer. So that's why you got this topic, is because you told us you would like to hear from SAMHSA and others about this topic. So, and I want to thank our SAMHSA friends for providing the data, and how to, what I learned from that is, okay, how to think about this data, what the gaps are, and then Mary's real life example. So yeah, it was really engaging, and I want to thank you all. And it's hard to engage data on Zoom, huh? But you guys did a great job. So I offer a sincere thank you for that work, because I was involved the whole time. And usually when data comes, I kind of gloss over, but did not in this presentation. So thank you very much for your time and the effort you put in, because those slideshows are not easy to do, and they were very detailed. I offer a blessing to you all, that you have a good rest of your day, and that spring has sprung in your area, I hope, and that you can see the flowers and the trees, and you're not experiencing hay fever. And if you are, that it's taken care of in a good way. And I wish you a good rest of your day. Meg typically sends out all the information that is provided in the chat box, so you will get that subsequently. And have a good rest of your day, everyone.
Thank
Bye-bye.
you.
Thank you.
Bye-bye.
Bye.
Bye-bye.
Everyone.